Hello everyone, and welcome to this audio podcast in this RPSG and KDOS collaborative aligned with another Storm Robotics production. This is an audio podcast surrounding Henoch Schoenlein Purpura. This is an audio podcast part of the Illmatix series. And so to begin with, to highlight Henoch Schoenlein Purpura, or abbreviated HSP. There was works that had been published in 2000 and in 2018 and been published in 2018 and there was excuse me, there was there was an effort where the works that was published was a review article on this particular sort of hematological and nephrological based condition, wherein the authors of the work look to answer the question surrounding what can we learn from biomedical and clinical anatomy practice on this multidisciplinary disease. And so in this audio podcast, I thought to provide a sort of an overview on HSP. So Henoch Schoenlein Purpura, or HSP, is characterized by by a triad of symptomology. Number one, where there's palpable purpura without thrombocytopenia. Number two, abdominal pain, and three, arthritis. Renal involvement also occurs in pediatrics and children with HSP. It is more frequent. It is a condition more frequent in pediatrics, or in pediatrics or young people from where there's a male predominance. And in spite of being a self-limiting condition, HSP can cause renal manifestations with various indices. In and around this, guidelines and treatment for managing care in such patients between there's varying sort of guidelines guidelines and frameworks in relating to treatment for managing care in patients with HSP, and it ranges between particular aspects of specialist practice. Long-term prognosis depends mainly on severity of renal involvement, which mainly manifests as persistent hematuria, proteinuria, nephritic or nephrotic syndrome, and or even sort of renal failure from the outset. And to prevent or delay end-stage renal disease, identification of early stage nephritis is crucial. Risk factors associated with renal involvement in HSP are not always clear, although epidemiological and clinical features as well as some abnormal abnormal laboratory findings have been suggested to have a predictive basis. And so the aims aims of this particular review around HSP were to provide a practical understanding of HSP, to provide an understanding of what further multidisciplinary care is required for patients with HSP, and three, to highlight how a laboratory practice could be enhanced to support the development of HSP care guidelines. So in and around the basis around HSP, Herein I'm going to highlight some aspects in regards to the epidemiology. Henoch Schoenlein Purpura is the most is one of the most sort of common vasculitis based conditions in children or pediatrics, occurring in 8 to 20.4 per 100,000 pediatrics or children per year. HSP usually occurs in children aged between 2 to 10 years, and with around 50% of cases occurred in pediatrics and children aged less than 6 years as well, mostly in pediatrics or children aged between 4 to 6 years of age. And although it is generally a self-limiting condition, HSP can cause acute gastrointestinal manifestations. So where there can be bleeding involvement and or manifestations with various indices. Age of onset is a suspect risk factor for renal manifestations in HSP. The etiology of HSP etiology around HSP is from a laboratory basis, a laboratory pathology basis is generally well known. However, etiology of HSP from a clinical perspective can be unknown in some contexts where there can be a variety of antigens involved, and infections and other aspects, other debilitating factors such as drugs or medicines, foods, certain types of foods, insect bites can trigger the onset of HSP in some regard. The disease is characterized by deposits of immunoglobulin A or IgA, which contain immune complexes and complement components in small blood vessel walls. It is generally agreed that the incidence of HSP decreases with age, and the proportion of pediatrics or children presenting with renal involvement reported in investigations varies from anything from 10 to 20% in children or pediatrics. The biomedical markers in around HSP can be useful and specific for HSP as well. So if present, anemia is usually a result of gastrointestinal bleeding or associated with acute nephritis. Thrombocytosis can be a feature that may be related to disease severity. Renal involvement results in hematuria as well, with or without proteinuria, which may be in the nephrotic range. A rapidly progressive nephritis may also result in renal insufficiency and requires histological assessment. Von Willebrand factor antigen is synthesized and is sort of present in and around endothelial cells, and high concentrations have been detected in patients with HSP as with other vasculitic diseases, probably because of the vascular endothelial damage. An association with a disease activity has been noted, and this may be a useful marker for disease for disease severity. Soluble thrombomodulin is derived from damaged endothelium, which may prompt endothelial injury. And raised serum thrombomodulin concentration have been demonstrated in patients in HSP with HSP nephritis. Routine coagulation investigations are normal, while factor 13 activity has been reported to be low, especially in patients with severe gastrointestinal disease. In context of chronic kidney disease, renal involvement rarely precedes the appearance of purpura, and usually occurs within the first 3 weeks of the illness. If it ranges, or HSP ranges, renal involvement and purpura ranges from isolated microscopic hematuria, proteinuria, or nephrotic syndrome, to acute rapidly progressive glomerulonephritis. It can be associated with either renal failure alongside arterial blood pressure abnormalities. Depending on the diagnostic criteria, the frequency of renal involvement varies from 20% to 100%. Yes, so again, I mentioned a proportion of previously. I mentioned a proportion of pediatrics or children represented with renal involvement. Reported investigation varies from 10 to 20%, and that was wrong. It ranges from 20% to 100%, as in the case as just highlighted. And overall, an estimated of 2% of children or pediatrics with HSP experience renal failure. In one investigation, the frequency of CKD in adults was estimated to be 1%, and that of end-stage ESRD or end-stage renal disease less than 1% frequent, 1%, and the frequency of renal failure was reported to be 10% to 20% in adults and 1% in children or pediatrics. Retrospective cohort investigations reveal some degree of initial renal involvement in about 20 to 54% of HSP recipients or patients, and ranging from isolated hematuria and or proteinuria without any abnormality in renal function and or arterial blood pressure, to acute nephropathy and renal impairment. In the published work, there's an overview surrounding the defining features of HSP. What I thought I'd do is highlight some of those particular aspects. So the defining features can be where it's a most common systemic vasculitis in children or pediatrics. There's vomiting. There's abdominal pain with gastrointestinal bleeding. There can be arthralgia, where there is sort of musculoskeletal or joint pain. Hematuria can be evident. Proteinuria can be evident. Nephrotic syndrome can also be evident. Systemic small vessel leukocytoblastic vasculitis can be evident, and purpuric skin lesions on extensor arms and legs, and sort of the behind can be evident as well. And so the in around sort of the criteria for hospitalization, there can be inability to maintain adequate hydration or with oral intake, severe abdominal pain or significant gastrointestinal bleeding, changes in mental status, severe musculoskeletal involvement, limiting ambulation and or self-care, and also renal insufficiency, where there's elevated creatinine, and evidence of symptomologies in related to nephrotic syndrome as well. So the one of the so in the works there was surrounding what can we learn from biomedical and clinical anatomy practice surrounding this particular disease or condition. And so in this context, I'm going to highlight some aspects in regard to the importance of multidisciplinary laboratory or pathology efforts. So streptococcus vaccines, viral infections that relate to measles, varicella, rubella, hepatitis A and B, tuberculosis, mycoplasma, Bartonella, Helicobacter pylori, are stated as sort of triggering factors in the literature surrounding HSP. And this is HSP is a multidisciplinary disease and affects the skin, can affect the skin, gastrointestinal system, renal pathophysiology, and in addition, more rarely, can have an effect on the central nervous system or CNS. Its pathogenesis and causal factors have not been accurately documented. And viral and bacterial infections, drugs and vaccines, food allergy, and even insect bites have been considered in the etiology of HSP, and is thus important to appreciate that where supporting clinicians with laboratory diagnosis, HSP requires multidisciplinary team and laboratory practice. The works, the paper, the peer review publication highlights sort of overviews in relating to HSP multidisciplinary team laboratory practice and efforts, and HSP clinical pathological findings, and also HSP microanatomy of the kidney and the small blood vessels. In context of biomedical and clinical anatomy practice, results of most of the routine laboratory investigations remain within normal limits. A normal platelet count can rule out idiopathic thrombocytopenic purpura or ITP. A normal platelet count and normal coagulation study results rules out thrombocytopenic purpura or TTP. A normal lipase level makes acute pancreatitis unlikely. Anti-nuclear factor testing or investigation, along with serum immunoelectrophoresis, anti-neutrophil cytoplasm antibody testing, complement 3 and complement 4, C3 and C4 investigations, and genetic typing are performed only when there's an overlap of syndromes, when there's an overlap of syndromes and the syndromes are suspected, and when there is palpable purpura, gastrointestinal symptoms, and arthralgia with or without proteinuria or hematuria, the diagnosis of HSP is generally then straightforward. In atypical presentations, severe and varied complication recurrences are more common in adults and children, paediatrics that are, for example, less than 2 years of age. Reduced glomerular filtration or GFR is linked with a worse long-term renal prognosis. Early identification of impaired renal function is important part of biomedical practice and disease progression. Hematuria is commonly present in HSP nephritis and usually runs a benign course when isolated. Macroscopic hematuria for more than 7 days in works that have been documented have been are rare and would require and have required prospective investigation to explore differential diagnoses. In around sort of the microanatomy of surrounding renal pathophysiology and the small blood vessels and blood vessels. There's acute, chronic, and skin bases around this. So from an acute perspective, there's leukocytoblastic vasculitis of small vessels due to deposition of IgA immune complexes. There's diffuse proliferation of mesangial cells and matrix without significant involvement of capillary walls or lumen. There's segmental necrotizing lesions and in around 50%, and endocapillary proliferation around 13%, and cellular crescents, glomerular acute, and chronic inflammatory infiltrate. In around the chronic aspect around HSP, there's glomerular sclerosis, there's tubular loss, and there's interstitial fibrosis and hyaline atherosclerosis as well, or can be, and skin interstitial fibrosis and hyaline atherosclerosis. In and around the skin, there can be hemorrhage and necrotizing vasculitis in dermal small vessels, and wherein they contain IgA, immunoglobulin A, and vasculitis is present in other organs, but usually not in and around renal pathophysiology. In context of biomedical practices to support development of HSP guidelines, biopsy and histological lesions of HSP nephritis have been grouped with an international investigation of kidney disease in children, paediatrics, and classification into 6 different categories according to the presence and the number of crescents in context of histopathology findings. And there is, however, a lack of consensus regarding the utility of crescents as a long-term predictor. Some studies or investigations have shown that a high percentage of crescents predicts adverse renal outcomes, whilst others do not. Therefore, there is a need for reliable, proven biomedical practice that can support both the development of HSP guidelines and support for clinicians to make more accurately formulated care plans for patients with HSP nephritis. In a sort of a retrospective systematic review, there was an investigation where children paediatrics were followed up with HSP and found to have an excellent overall renal prognosis. The review examined different lengths of follow-up after initial presentation of HSP, and showed that only 21 patients, which accounted for 1.8% of the total study population, developed subsequent renal involvement. Follow-up with urinalysis and other investigations had been recommended. However, the ideal duration to follow up was and had been unclear. More retrospective, and then that particular investigation that took place in around 2005. In 1995, there was investigations that revealed a favorable short-term prognosis for the initial renal involvement in most HSP patients, with complete resolution of 94% in pediatric patients and 89% in adult patients at an average of 18 months follow-up. So in and around the discussion around this works. So the pathogenesis of HSP remains sort of unknown in some context, although again from a pathology basis, HSP as part of the diagnosis requires other investigations to confirm. However, it is generally considered to be an immune complex mediated disease characterized by the presence of polymeric IgA1 or PIGA1 containing immune complexes predominantly in dermal, gastrointestinal, and glomerular capillaries. The pathogenomic granular IgA and C3 deposits in the mesangium are indistinguishable from those seen in IgA nephropathy. Similar histological findings have also been observed in in the kidneys of recipients or patients with liver cirrhosis, dermatitis, hepatic with liver cirrhosis, dermatitis, the hepatic form of the hepatic form is a celiac disease and chronic inflammatory disease of the lung, where light microscopy is concerned. Renal morphology in HSP cannot be distinguished definitively from that in IgA nephropathy, as the glomerular lesions are similar and vasculitis is virtually never observed within renal parenchyma. With the use of more proliferative lesions, there may be more intense sort of staining, more intense sort of histological staining in some capillary walls. Fibrogen can be seen in the urinary space with crescents when crescents are present. Using electron microscopy, there are variable visceral epithelial cell processes along with capillary basement membrane thinning and thickening and lamination depending on the degree of glomerular injury. Future biomedical laboratory practices can help inform clinical decision making in the care of pediatrics or young people with HSP. More case and longitudinal investigations would be helpful to understand whether patients would benefit from different care plan options. Prognosis is generally excellent in pediatrics, where 50% have spontaneous remission, but poorer prognosis can be poorer in adults, and or where there is nephrotic syndrome as well, or can be nephrotic syndrome as well. With in line to sort of the conclusion around this with biomedical collaborations, and whilst biomedical collaborations are imperative, the most accurate prognostic factors are histological, the percentage of crescents, and the presence of interstitial fibrosis and extension of mesangial deposits correlate with the risk of CKD. The risk is highest in children pediatrics with crescents in more than half of the glomeruli. In adults, even with even fewer than 50% crescents, in adults, even fewer than 50% crescents have been documented as unfavorable as part of the pathology. In the course of persistent renal sequelae, are further renal follow-ups cannot precisely be predicted by histology, and long-term follow-up is generally thus warranted in and around HSP patients. Evidence informs again that male gender age greater than 10 have symptoms of severe gastrointestinal, can have severe symptoms surrounding gastrointestinal involvement of arthritis or arthalgia. So the question again, and in ending, so what can we learn from biomedical practice on this multidisciplinary disease? So much like hemolytic uremic syndrome or HUS, where there is a triad clinical syndrome, HSP has similar pathological consequences and laboratory involvement. Certainly well-designed and conventionally reported investigations in histology, microbiology, hematology, and laboratory collaborations are still required to identify HSP disease development and progression. Yes, in around this audio podcast, and in ending this particular audio podcast, just like to acknowledge the founder of the Renal Patient Support Group, one of the founders of the Renal Patient Support Group, the RPSG, John Gardner, who knows very much what it's like to live with and have HSP. So this draws this audio podcast to a close. This has been an RPSG and KDAS collaborative, and this is an audio podcast as part of the Illmatix series. This is an audio podcast surrounding Henoch Schoenlein Purpura, and it's been another Storm and Bostic production with the Shientist. Thank you for tuning in.